Everyone. This is Direct Line, Montgomery County Republicans Club's featured show. Our guest today is Dr. Jeremy Ackerman, MD, PhD at FACEP. I butchered that, didn't I?
You actually got it out right, Dwight.
And our host is Mark Unkerfer and myself, yours truly, Dwight Patel, our guest and my old friend, Dr. Jeremy Ackerman. Welcome.
Well,
thanks for having
welcome. Correct me if I'm wrong. I don't know if it was the last time. I may have missed the last show, but at least the show that I was on with you last was, I believe, in May of 2020. And we were talking about COVID, and obviously we were in the throes of the pandemic, and a lot has happened since. So let me throw the question everybody wants to know. Is there going to be a time when it's back to normal and we can go out and be safe again?
I think we'll get back to where we can be safe again. I think normal is going to ultimately look a little bit different than, 2 years ago. A lot of the infectious disease docs that I talk to are sort of concerned that we have enough of the virus out there and mutations and variations are popping up frequently enough. And we're discovering things like, deer seem to be a reservoir where they're finding COVID in the deer in the woods, which is a little bit ominous that it's going to be something that will pop back up again, even with vaccinations and other treatments that we have. And so some of the things that, in some places we're getting used to, at least when we're coming together in larger groups, trying to get people to do masks, being more conscientious about things like hand hygiene, I think generally are going to stick a little bit more. I think we're going to get better at figuring out how to come together safely, even in the face of COVID as an ongoing threat. But I don't think it's going to be one of those it's defeated and we're done sorts of things. I think it's going to be similar to sort of seasonal flu, although we may not have a clear season for it. It may just be it simmers and then pops up and then simmers a little bit more.
So we may be doing boosters well into the future now. And boosters may be reflecting, I'm jumping ahead, I guess, but additional strains that have popped up, and so adjustments can be made there. Is that?
I think that's where we're probably headed. And this generation of vaccines is kind of interesting because it's built on a technology that actually makes it much easier to rapidly create new vaccines, slight variations on the old ones, and deploy them. So it's kind of interesting to have something that we're concerned about mutations like the flu, and already have a vaccine platform that's in place that should be fairly adaptable if we get major strains that are resistant to past vaccines. I think we're still going to be learning, this type of vaccine, how long people actually have immunity. We probably will get better at figuring out who is not going to respond as much to the vaccines, and who's going to need extra doses, more frequent boosters, and who should be okay with less frequent ones.
Now, you may appreciate, since you grew up in Montgomery County, that there were CDC figures that suggested that Montgomery County had like 99% plus vaccination, which is reasonably stated to be a statistical impossibility, right? But I'm wondering, was that people going out and getting like multiple vaccinations on top of the ones that they were getting already? Is that a phenomenon at all? I'm sure you've never had that particular question before.
Yeah, so there definitely, before boosters were approved, there were definitely people who were getting a third dose because they heard that it was going to be a thing. There were physicians that were even administering third doses well before there were any recommendations about it. Some of that was coming from realizing that, unfortunately, while the vaccines are very good, and actually compared to historical vaccines, they're better than many of the vaccines that we've been using for a while. There's still a chance that somebody who's been vaccinated will, in fact, get the disease. And I think that particularly doctors who were seeing some of these breakthrough infections started going, well, maybe we should just go ahead and do that dose.
Yeah.
Because we don't have a true vaccination passport system or something like that, figuring out where all these doses are going and turning that into a reliable estimate of number of fully vaccinated people gets to be a little bit of a mess for health departments.
Yeah.
So, yeah, I don't know how they came up with that number exactly. It's probably off, but it is still probably reflective of one of the highest vaccination rates in the country. As opposed to down here in Georgia, where statewide we're hovering just below 50% fully vaccinated.
It's pretty good for Georgia, isn't it? Seriously, for Georgia, the size of Georgia, and I mean, I've been to Western Georgia, down back where my uncle lives, and you can actually see abject poverty. Like, you go down to Albany, in those regions, you can actually see poverty. I mean, it's like nothing we've ever seen up here in Montgomery County ever before. But
forgive me, in Georgia, there's like Atlanta, and then there's the rest of Georgia, right?
Yeah.
But
you got Athens
really raises an interesting question.
Yeah. But
yeah,
Jeremy,
and down here we even have things, in some of the rural hospitals, when the hospital systems had started rolling out vaccine mandates, there were physicians who were refusing to get the vaccines, and nurses refuse. So people within healthcare that you would hope would be educated enough to understand the value in doing it, who just weren't doing it. Unfortunately, you can also track in those counties and areas, the infection rates and the death rates are so much higher than places where the vaccination rates are better.
Now, quick question about, and this is just my armchair, talking to my hypochondriac friend and myself, who's not a hypochondriac, but of the three vaccines, are you a little bit surprised how J&J is actually not as, everyone always said J&J was probably the worst of the three to get, but it's turning out that's actually not the case. It's actually Pfizer is turning out to be like probably the worst of the three. Any surprises there?
This was one of those things. The surprise is probably more that it's the sustained immune response. Mm-hmm. So the initial response, the data still says Pfizer is better, but when you get out months out, the finding degree of antibody production just declines differently across them, and until you do the big experiment and you do the experiment over enough time, it's kind of hard to predict. It's not something that I've followed very, very closely. Where we are, the push still is to get people to get a vaccine, any vaccine. Mm-hmm. And if people end up needing a third dose or something like that later, mm-hmm. We're not even worrying about third doses in most people here. We're just trying to get anything into them.
And also, I'm sure you've heard about this. Last couple of weeks, they've been talking about Pfizer. Was it Merck and Pfizer both have a pill, which is in essence like Tamiflu is to the flu as this would be to COVID, where it cuts down.
So they're fascinating drugs. They're antiviral drugs that basically disrupt the replication of the genetics of the virus, similar to the antiretrovirals that are used widely for treating HIV. And I do have to put in a plug to my main employer. One of those drugs was developed initially in an Emory lab. That was the Merck one, which got approval for use in the UK. So it's really encouraging to have something other than vaccines. But ideally, what we want is to be able to decrease the number of people ahead of time who don't, who don't get the infection in the first place, whether it's from wearing masks and hygiene and those sorts of things, vaccination, and then when people do get sick, having some treatment options that keep them from getting severely ill. Until these drugs are available, really our only good thing that seems to make a difference other than steroids and good supportive care is the monoclonal antibodies, which is great, but requires an IV infusion, does have a significant rate of things like infusion reactions. So it's probably in the long run not the best choice. Certainly not something that can be deployed outside of a fairly sophisticated health system, because it's an IV infusion that needs to be stored properly and all of that. So the pills are really kind of a great breakthrough if we can figure out how to distribute them to where they're needed most, which is probably not going to be in the United States, given that, places like Georgia and Mississippi aside, our vaccination rates are getting to be pretty good.
You touched on it already, which was the issue of, or the way in which the new vaccines have been manufactured, the improvement that allows for the technology to be the most recent variations to be updated. First of all, could you just, it's probably worth elaborating the relative effectiveness. We're kind of talking about the various vaccines relative to each other, COVID vaccines, but just how dramatically improved that is compared with the best flu vaccines that we've had over the years.
Yeah, so flu, there are multiple issues around effectiveness of flu vaccines. The flu as a virus is one that, because of its structure, mutates very, very quickly. And what happens in each flu season is the infectious disease docs sort of track which strains are emerging and try to come up with a best guess of what the most common strains of flu are going to be. Because there are specific proteins on the surface of the flu virus, which are what the vaccine has to be targeted against. And the different strains have different proteins there. And the problem with the flu is that the lead time in making these vaccines is enough months that sometimes by the time they've rolled up production to create the new vaccine, a different strain is now the dominant strain. And so in addition to having a vaccine platform that maybe only 60-70% of people are going to make enough antibodies to actually be truly immune, you also have the issue that sometimes the vaccine that we're giving doesn't match the dominant strain. And so then it doesn't matter how well your body responds. If you get a strain of the flu that's not what you were immunized against, it's not going to help you.
Yeah, I mean, I'll tell you, every time I've gotten the flu shot, Jeremy, I come down with the flu. I've gotten the flu shot like 3 times. All 3 times got the flu, and it was a really bad version of the flu too.
Yeah, and that probably reflects over the last 10 years or so, we've had some pretty nasty strains of flu, and we've only had a couple of years that the flu vaccine actually was well matched with the strains that we got. And we've even had a few years where we've had multiple strains of the flu, and the flu vaccine wasn't active against any of the strains. And it meant that even though we usually think about getting a disease only once in your lifetime or once in the year, it was entirely possible to get the flu in most areas twice because of the 2 very different strains that popped up that year.
Now, speaking of the last year, we had pretty much a zero flu season at all. I mean, nobody, because everyone was masked up, everyone was staying indoors. I think, what was it? I think, what did we have in the entire country? What, about 100 to 1,000 cases of the flu in the entire country,
Something
probably?
like, yeah.
And now, does that mean this year it's going to be back with a vengeance? Because, people are not wearing masks everywhere, and that's, because they've got the vaccine. But is this year's flu strain going to be harder to predict considering they don't have anything to really go on from kind of like a previous?
This is part of the new normal. I don't think anybody really knows what this is going to look like. As much as more people are not masking, and certainly from a COVID perspective, for many vaccinated people in many areas, that's not an unreasonable thing. I think there is a little bit of some of the precautions that we've been taking in various places are still in place. You go out to restaurants and the tables are spaced differently than before. And some of that is because health departments are requiring it, and they come around and, you don't pass your health report if you're not following the health department's guidelines. In some areas, places are maintaining that because people are more comfortable with it. And all of those little things may help lessen the severity of flu. Hand washing is super important with flu. So, that habit that more people have of hitting the hand sanitizer and being careful about hand washing probably will help. So I don't know. At the same time, from a hospital perspective, we are dreading having COVID and flu at the same time. We've already started, when we're doing those nose swabs on everybody, we're already testing for flu because we're very concerned about what that's going to do to the hospital if we're still in the middle of a pandemic from COVID and we start getting into not even a really bad year with flu, but a kind of bad year with flu. And at least so far, we haven't been seeing cases, but that will change.
And I mean, we have people like our president of our Montgomery County Council, Tom Hucker, who has actually floated the idea of bringing mask mandates for the winter, and limit the indoor capacity for winter months to combat the flu. Because he says, I'm thinking past the pandemic and and I'm thinking that's a little bit extreme. I mean, we've had the flu around for a while. I think it's getting a little extreme on clocking down for the flu season.
It's sort of interesting when you look at other parts of the world. There are parts of the world that people regularly wear masks, and when you start normalizing for other things, they tend to get a little bit less flu than those of us who our convention is to not be wearing masks in public gathering. It's probably worth having a healthy discussion about it. I'm not quite ready to chime in with a ringing endorsement, but I'm also not quite ready to say no, don't do that. There's a little bit of a challenge because enough people have to do it to have it make a substantial difference. And I think there are probably some people that just the idea that they might reduce their own personal risk is enough to have them just continue to use the mask.
And I think my 2 cents on the whole, mask mandates and this, full disclosure, I love the vaccine. I got the J&J vaccine. I'm getting the booster next week. Vaccines are a wonderful thing. Masks, I say, it should be, if you don't feel comfortable wearing a mask, don't wear a mask. And if you're fully vaccinated, you don't feel comfortable, don't wear the mask. If you feel like you want to go into the supermarket with a mask on, wear the mask on. I'm not going to look at you funny for having a mask on. Don't look at me funny for not having a mask on.
So for public health purposes, though, we should probably ask Dwight whether he's gotten the flu vaccine or not, because that may be a counter indicator as to the likely severity of the season. What do you
considering think? And actually the last time I had the flu, Jeremy, the Tamiflu, I swear, made the flu worse because I was getting seasick from the Tamiflu. I think if I never took the Tamiflu, I would have been done with the flu in 5 days, opposed to the 2 weeks it took.
So he didn't answer the question whether he's got
No,
No.
I have
the
no,
vaccine.
no, I have not. I have not
Oh,
taken the
okay.
flu vaccine. You know, but I did take.
Yeah.
I did get the shingles vaccine, even though I'm not 50. I got that though.
I was gonna say I didn't think you were old enough, but you went for it. Okay.
Yeah,
So there's an
they asked when I
example
was
of
at the
why Montgomery
doctor's.
County's numbers are so high is you have people that are outside the category, taking multiple dosage and additional thing. Let me ask a question, a little shift gears, is that you do have yet another hat, which it's a term that I had never heard before. Obviously, we've talked to you quite extensively about emergency medicine, which is your specialty. But one of the other areas that you're involved is tactical medicine.
Yeah.
And can you explain what that is and what that involves for you?
So tactical medicine it's largely a subspecialty within emergency medicine, although certainly there are other doctors, medics, nurses, nurse practitioners, physician assistants who get involved with it. That centers around providing care to those who do tactical operations, whether that's military special forces, or actually even general military operations. So care in the field. In the civilian world, it's usually law enforcement, usually serving SWAT teams. And then the other piece of it is it's about having the officers ready and prepared to take care of themselves, but also ready and have a team ready and able to take care of those around them while we're doing tactical operations. So many of the people who do it are ER docs. There's some that do fellowship training in emergency medical systems and then kind of focus in on tactical medicine. And there's a wide range of what, from a physician standpoint, tactical medicine looks like. There are folks that basically are medical directors. They work on making sure that teams are trained, properly equipped, and sign off on their kind of general orders and their standing orders. And then there are folks like me that actually deploy with a team, even going so far as going through full police training, having a badge, carrying a gun, and actually directly participate so that we would be right there if somebody's injured in the course of an operation. Um, Part of my motivation in getting involved with this was realizing that, unfortunately, when we've had some of these mass casualty events, particularly some of the shootings, there's often a big delay between when law enforcement decides that probably the shooting has stopped and is largely in control of the situation, and when conventional medical resources are able to get on scene. Most ambulance crews, most doctors and nurses really won't and should not go in someplace where shooting could erupt once again. And even working in that environment where we think it's safe requires a good understanding of how the tactical teams work, some training, some equipment about what to do if things suddenly become unsafe again.
So some of it would be, for example, the experience, the expertise or training that a field medic would have, but obviously broader than that as well, to anticipate some of the other preparatory advisory function with units.
Yeah, it's an interesting place to practice medicine because all of the things that I do in the ER, a great many of them, I would never do in the field, in a tactical setting. We're largely worried about traumatic injuries and mostly from gunshot wounds, possibly explosive injuries. And it turns out there's only a very small number of interventions that are truly life-saving. And really the key is to get everybody on a team, including the physician there, having a mindset to do those few interventions and have a good understanding about how to get that injured person out of the threat environment and on a transport and on their way to the hospital, where all the other things that I'm trained to do suddenly become relevant and possible to do.
So a lot of it is just getting out of the harm's way to getting to better resources.
That is a huge consideration. One of the things that often people don't think about, and the question that I ask residents and medical students who are interested in it is, if we are in a tactical setting, somebody's shooting and somebody gets hit, what is the biggest medical threat to the person who's been shot? And the students usually go, oh, they'll bleed to death, right, and they're thinking about the injury that person has sustained. And what I point out is actually the biggest threat is them getting shot again, right? Or the team that's trying to rescue them and getting them out not being able to rescue them, as opposed to the bleeding and all of that.
Got it. Okay.
And so it's also a setting where part of figuring out how to rapidly get somebody out is also reducing the threat. And that's where having, whether it's a doctor or a medic that's going into one of those situations, you need to have the understanding and arguably the training and the equipment to shoot back, because the shooting needs to stop before you can really focus on doing the medical care, because that person who's shooting is still the biggest threat, both to the person who's injured as well as to everybody else. And if you're not ready and prepared to address that threat, it's not a good place to be.
And what do you call? It's like what do you call? Looks like you've come full circle. You were an engineer, then you went to med school. And so what's next after this? Are you going to join the bomb squad, or what's next?
I don't know. I don't know. I keep on threatening to go to law school, but I don't think I want to go
We
back.
always need more lawyers in this world, Jeremy.
Well, it's interesting. Dwight said you went full circle. We were talking before that. I guess the tabloid headline would be that you brought a gun to school at Blair High School, but that was actually quite legitimate because you were on a team that
But you know who else would bring a gun to school regularly was Marcus Alzona. He was on the
we really
team
should be
also.
careful how that gets presented, because
that could get out there wrong.
Flips. It was quite legitimate.
Marcus was on our rifle team. I don't know if you were on with him when he was doing it or not.
I think we had a 1 year of overlap.
Yeah.
So, but my experience on being on the rifle team actually is a big part of why this has worked out to actually be in tactical medicine. Sort of ironically in all of this, I started reaching out to law enforcement because of a colleague who was working in firearm injury prevention. And what we realized over a series of conversations that I think conventional medicine has kind of gotten wrong in terms of reducing firearm injuries, is largely taking a political view of it, which is problematic. So if we take the standpoint that guns actually are bad and we should ban them and all of that, that's just not going to happen, because the laws will be difficult to pass. And even if they're passed, we've got years of legal challenges. So if we want to do something about people dying from firearms now, we need to be a little bit smarter about it. And the other part is, if we look at who's dying from firearms, the vast majority are people who own guns and their family members. And unfortunately, the biggest number of people is suicides. And that's something where a physician really should have a role of helping people understand what their risks are, and not necessarily arguing, hey, get rid of all your guns. But if somebody understands that, hey, I should have a plan if I'm having a mental health crisis so I don't have access to my guns in that event. That's a much smarter way to approach this, large number of people who are dying every year. But it requires something that medicine has not really done well historically, which is engaging with the firearm community rather than saying things that sort of piss everybody off. And so this colleague of mine, we came up with the idea of basically doing a class for doctors to help them understand basic gun safety, to enable them to have smarter conversations with patients. So not being adversarial about it, but saying, okay, there are some risks here. What can you do? What steps are you taking that, if you have guns in your home, can help keep you and your family safer? And opening up the door for conversation. So that led me to reach out to law enforcement because we realized that this would be expensive to do as kind of a class, because it needs to be done essentially at a gun range, and you've got to pay for that. And if we assume a lot of my doctors don't like guns, they don't want to go to a gun range and pay to learn about something and support an industry that many of them don't like, right? So I had the idea that law enforcement has firearm instructors, they have guns, they have ranges, and most law enforcement officers, I figured, would like to be good friends with their local ER doctor. So I started reaching out to law enforcement, kind of got nudged towards the tactical teams. And one of the teams I was reaching out to had just lost all of their medics. Sorry about the noise. My dog is trying to make his bed. There he goes. Okay. So they had just lost all their medics because of a political thing. So I had kind of said, look, I'll help out with your team until you get your medic thing sorted out. And but I realized I didn't know much about how the tactical teams worked. So my deal with them was that I had got to go to their training days. And on one of the training days, they had been shooting all day. And at the end of the day, one of the guys looks at me and goes, "So do you want to shoot?" And I'd just been watching the whole day. And so they handed me a rifle, and they're like, okay. What they had me shoot at was a school bus. We had a one of those small school buses parked on the range to practice doing hostage rescue on it. And it was about 25 yards away, and they were like, shoot the bus. And, that's a big target for 25 yards away. So I decided to shoot the one part of the bus that there's no metal on, not thinking about how there's no metal there. So I was shooting one of the rear turn signals, which is about a 3-4 inch circle. And the gun had a magnified scope, so I could see that every shot was punching a hole in the little piece of plastic back there. But they didn't have a magnified scope. So I could hear they were kind of whispering. I had my electronic ear protection on with amplification, so I could hear them whispering really well. And they were like, what? He's not hitting anything. So one of them starts walking up to me, and I can hear his footsteps coming up. And I realize they don't think I'm hitting anything. So I just start calling my shots. So I'm like, left upper pane, pop, right? And I just start aiming for pieces of glass or metal where something is going to happen when I hit. By the time I got to the end of the 30-round magazine, they had changed their tune. They're like, Doc can shoot. And from then there on, instead of just having me watch training, I kind of nudged, hey, you've got to let me participate in training. And a big part of why that worked is, 20 some years earlier, I was shooting competitively, and that bus was not very small targets and not very far away, but it was very easy to just remember the muscle memory from all that shooting before and get back into it. Switching over to handguns was a little bit more of a problem. Hasn't been that much of a problem, but that took a little bit more doing than the first couple times picking up rifles.
There are actually kind of two ways to go. It's kind of fascinating. Obviously, we heard a little bit how the police reacted as they learned that you could shoot, and I guess kind of created But tell me a little bit about how other doctors have reacted to this, because I know that there is, I think we're all familiar with the kind of very strong cultural divide that exists in this country around guns. That sometimes seems hard to bridge. And so it's fascinating to hear the kind of efforts that you've had to make that connection.
Yeah, so it's been interesting because I've been trying to bring some of what I've been learning and getting into the space back to the medical students and residents that I train. And some of those efforts have been met with a lot of concern and resistance. And I think over time, either I'm wearing people down, or some of what I talk about, some of what the residents and medical students learn has broader value than just doing tactical medicine. Um, you know, part of what you have to do is think on your feet and reprioritize a little bit how you structure care in a way that actually applies fairly well in the emergency department. It's not how we normally teach it, but it works. And so I think having things that I can bring back to medicine from how medicine is adapted and use it a little bit more broadly has been good. I actually have a paper coming out in the AMA Journal of Ethics in February. And the original title of that paper was, "Doc, when you're here, it's easier to keep my finger off the trigger." Which comes from something that probably the fourth time that I rode with my SWAT team, it was a particularly high-risk situation. We had an arrest warrant for a suspect who knew we were coming, had posted all over social media that he was going to shoot up all the cops with pictures of all the guns that he had. And one of those things that all of us, I think, were a little bit more keyed up, a little bit more nervous about what was going to happen. And the whole situation played out. We did what we do. No shots were actually fired. We do a little bit of a shock and awe and kind of demonstrate an overwhelming amount of power available. And that usually convinces people to surrender appropriately. But one of my guys coming out of that house, just walked up to the back of the armored vehicle that I'm usually hanging out in during these ops, and says that. And obviously, we're talking about a highly trained officer, not just a patrol officer who goes out to the range, went to the range a lot in the academy, and qualifies a couple times a year, and may not draw their weapon hardly at all. We're not talking about a civilian who also, should know the basic safety rules, one of which is keep your finger off the trigger until ready to fire. And the recognition that the stress and knowing what they're up against, that people, despite what we're trained, get their finger on the trigger when we shouldn't. And it's dangerous. And it means that officers are more likely to get hurt. It means that suspects and random innocent people in and around where we're working are more likely to get hurt. And so I realized when he said that was sort of a reason, not just for my team, but for everybody. That's a good reason for me to be there. If my guys are more focused and doing what we're trained to do the way we're trained to do it, it's a win for everybody. And it's one of those things. This is sort of an ethical conundrum. Like, do I carry a gun or not? We think about the Hippocratic Oath. Everybody sort of summarizes it as first do no harm, which actually is not in the Hippocratic Oath, but it's what we normally think about as being the Hippocratic Oath. And modern medicine, we can't really ever guarantee doing no harm. Everything we do carries some risk and could cause harm. And so what we actually do in medicine is we balance the risks. And so the way I look at it, the benefit of having somebody like me available to go in when there's an active shooter who can get 2 people the minute the bullets stop flying, because I'm trained to go in and understand how to work in that setting, is a huge potential benefit. The keeping a team better trained and prepped, and so that they can focus on doing things the right way, again, reduces the risks to a lot of people. Whereas in general, that threat, that harm that I might cause if I had to use a weapon, is really only about one person. And it's about a person who is an imminent threat to me or to other people. So it's not a simple balance. I am very certain that the way I balance things out is unique to me, and other people legitimately should play that balance out in their mind a little bit differently. Obviously, to even get in a position of discussing it, you have to be somebody who has the training and the willingness to get the training to be able to do all that. So yeah, it's a little bit nuanced. And most of the physicians who've expressed concern about sort of the idea of an armed physician, when we've had the bigger conversation about the potential benefits, usually instead of saying no, you still shouldn't do that, usually they're like, well, that's not the decision I would make. I've even had a few say it's not the decision I would make, but I'm glad that somebody's willing to do it.
What's
So we'll
fascinating about it is many of the kinds of situations that you're describing are in, high intensity and split second of being able to respond appropriately. Quite apart from these broader sort of philosophical questions, ethical questions, which if you had the luxury of time, as you described, you could argue it both ways and upside down and inside out. But
yeah.
you're really talking about being trained for it, to exercise what you would
Yeah.
regarded as
You have to make the ethical decisions before anything happens.
right. Yes.
There is no time for ethical decision making. The decision to be there, you've made your ethical decision. Yeah, the training, part of why I went through the police academy is to be able to do this right. I think that you have to essentially have the same level of training as the SWAT officers. So in the last 2.5 years, I'm probably, by the end of this year, I'll be up to 1,000 hours of law enforcement training. An awful lot of that is specific to SWAT, and 400 is, the general basic law enforcement. But almost all of the other things is SWAT, tactical training, shooting, other weapons, advanced tactics, all of that.
Well, we're coming up on our 45-minute point.
Yeah.
I wanted to come back to kind of COVID. I mean, and I wanted to kind of give you a chance. Obviously, we talked about the response in Georgia, and when you're talking to somebody who's reluctant to get the vaccine, what is your 30-second sort of elevator speech about why they should, or to help them overcome their objection? Why they should, or to help them overcome their objection?
So I have. It's difficult at this point with the folks that I'm seeing who don't want to be vaccinated. Usually the way that I get them vaccinated is I go, we are offering vaccines here in the emergency department because it's that important. And down that hall, I've got 15 people that are headed to ICUs because of COVID. Would you like a vaccine? I've sort of found that most people in the emergency setting, it really comes down to do they just need a little push over the edge, or is this somebody who's sort of dug in and they just don't want to do it? I had a conversation with a police officer who was very concerned about vaccine mandates that are being rolled out in a lot of police departments. And he was like, I'm going to quit before I do that. And he kind of went on a rant about, there's no legal basis. I'm like, you have kids? He's like, yeah. Did your kids get vaccines so that they could go to school? He goes, yeah. I'm like, do you see that there's some commonality here? Like, it's a different situation where we've got a kind of imminent and ongoing threat. Like, it kind of seems like a stronger case to me, as much as it's really concerning when we have parents that won't vaccinate kids. And now we're seeing outbreaks of diseases that we haven't seen for years. Things like mumps. I mean, that really shouldn't be happening, but people are refusing those vaccines. And and he's like, yeah, okay. And he asked me another question that was clearly about getting some information to build a case about why he shouldn't get vaccinated. And I said, we're friends, right? And he goes, yeah. I'm like, I'm not gonna help you make excuses. Like, you've heard my opinion. I don't think I'm gonna change your mind. I want you to think about what I said. I think it's important, but we're too good friends to argue about this. You've heard my concerns. I don't know if he actually turned around and got vaccinated. I know he hasn't been fired. I'm not sure if the deadline has actually kicked in yet. But I think sometimes in this, less is more in convincing people. So picking hey, look at vaccination rates by state and death rates by state. Like, there's a connection here. In states with higher rates of vaccination, the per capita death rate from COVID is much, much lower.
I mean, look at our state of Maryland. We're like we're the poster child for doing things right. I mean, I think we're leading the country on the boosters as well. I mean, I think our state might be close to, what are we, 70%, 72% vaccinated right now in Maryland overall.
Yeah. So I think my arguments tend to point to picking a couple of sort of facts that are the most compelling things, and not engaging in the sort of petty arguments that often these kind of discussions unravel into.
Right.
And I think importantly, as a physician, part of it is I need to express that I care about, whether it's friends, patients. I'm recommending it because I care about your health. And, we're not going to argue about it. This is my recommendation. Here's a piece of data that I think is most important. And think about it. I think it's easy to get caught up in the argument and lose sight of the benefit.
I think that's great. That's great advice and a great approach. I will just kind of interject one thing. What's great too is it isn't the reference to follow the science, which I worry that sometimes that has the impact of sort of reverse response for people who say, well, you're calling me dumb for not following the science. And then it's a conversation that goes off in a different direction. You are framing it in terms of concern for a particular individual.
Yeah. And the other challenge is that the science is really complicated. I should say the way we do science is complicated, right? We do multiple experiments, and most of us who've been involved in doing science know if you do enough experiments, you'll get an experiment that gets a result that isn't actually true. It will happen eventually because it's all about statistics, right? Nothing's 100%. And so that means that you can always cherry pick facts and studies here and there that this study said. And so even the point to following the science, if you're taking in all the science and you're doing rigorous meta-analyses where you're looking at all the studies and reapplying all the statistics, okay, sure, follow the science. But I think that some of these larger numbers that truly reflect what sort of the science says, like if what all of those meta-analyses say is true, this is what we should see, on a state-by-state level, given vaccination rates, and it largely plays out. So I think the simpler argument without trying to debate the science is really probably the best way to go.
Sure.
Particularly since I can't keep on top of every single study that's out there. There are new studies every day. There are new wrinkles of COVID that we're uncovering. And so following the science is actually a lot harder than, using that as a slogan.
Right. Well, thank you very much. We really appreciate having you back on again. And actually, we have learned a lot about it, a lot of different aspects of medicine.
And, I'll tell you this, Jeremy, and I think I shared with you the back cover of our convention program. You've got some fans who love watching you when you're on our show.
That's what I've heard.
We've got one who's, your number one fan. He was telling me, he was actually going to co-host tonight, but there was a election they had, and it went better than expected as a result. He's been busy with that sort of stuff, but in addition to that, I mean, just regular viewers of our show, they really, I think the best compliment we got was we had our convention a few weeks ago in Western Maryland, over in Flintstone, Maryland, where somebody said, I like it when you have Dr. Jeremy on. Dr. Jeremy just lays it out in plain, simple English. He doesn't go, give me all these technical jargons terms and so on like that. So, your message is getting out, and you're developing a fan base.
Yeah, well, that's pretty awesome. Sometimes it's challenging to find simple ways to express very complicated ideas, but it's a very powerful approach. It's good communication, and sometimes it lets us express what's most important to be said. So I appreciate those fans out there.
Thank you, Jeremy. We definitely want to have you on again very soon, maybe sometime in the new year. And thanks again. Much appreciated.
I look forward to coming back sometime.
Absolutely. We love having you.